Thanks, Tamsin, and thank you, Minister, and thanks to Uncle Tony for a very, very warm welcome. So we're talking about from policy to people today. So I'm going to just give, this is just a pot-shotted bit of a history, some thoughts of mine about how we got here, how the policy arrived in this, to where it is, and how some of these policies that were implemented in the other side of the world over nearly 100 years ago, more than 100 years ago, still affect us now. So again, thanking Uncle Tony for his generous welcome, and acknowledging people with lived experience of harmful substance use, and acknowledging that we're all a bit different. We all draw on the experiences that we have. So thank you again for having me. For those of you who are dedicated VADA conference goers, I apologise. I'm 3 for 3 now. And so from Scott's point of, it's Scott who organises these things. So if the VADA board would like to take up the rule on the right, feel free. I'll leave that with you. So the background, historical background. So the history of drug use was that in the 19th century, drug use was kind of unregulated. You could have a drink at home or at a saloon. You could order laudanum, could be delivered to your house. You could go to an opium. So they weren't called opium bars; they were called opium dens, which is interesting. It's an interesting aspect of it, which feeds into what changed things. So things started to change for a range of reasons. There was kind of moral reasons. People had the impression that drug use and the use of alcohol, interestingly, was a moral problem. And the picture on the left there is interesting, I think, in the context of the way we see family violence now, when we know that 65% of family violence incidents are affected by alcohol. I think that from hundreds of years ago, 100 years ago, still has relevance today. So there was a movement to change things. And what happened was that in 1914, I'll talk about this Harrison Narcotics Act, which was a huge deal and still affects a lot of what we do today. And then there was prohibition in America, and I understand this is American, as I say, these are policies from the other side of the world, but they still affect us now. So prohibition came in, it was a constitutional change. Can you imagine a referendum in Australia voting in that we're not going to allow alcohol anymore? Quite significant. So the policy, the Harrison Narcotics Act, it sounds like a boring thing. In 1914, what they decided was they wanted doctors to be able to provide these medications. So coca and opioids were to be regulated by doctors and dispensed by pharmacists. This was kind of a good, relatively good thing to keep things under some control, of regulation, if you like, regulated supply. But what happened was that the tax agents, it was put under the Tax Act, and the tax agents, the accountants, decided that it wasn't within the remit of doctors to provide drugs to people who were drug dependent. And they started prosecuting doctors. They started sending doctors to jail. And unsurprisingly, this had quite an impact on doctors and their policy and their approach to dealing with people who were using drugs. And I apologise here if there's some phrasing that is historical, so please don't take any offence. But what this meant was that doctors pulled out of the scene, and people were left, no longer considered to be patients, but considered to be criminals. It's quite a significant change. And that's followed through today, I would argue. Doctors are still not involved, and still rarely involved in treatment, and a whole system has developed without a medical practice involved. So what happened after that? The prohibitions happened in the 30s. There was the Kentucky Narcotics Farm and another farm, which was basically a place where people could go to dry out. And famously, the Kentucky Narcotics Farm probably had the best jazz band ever in history at one point, from people who were moving down from New York to dry out and then going back. But it wasn't really part of the system. People were separated out of it. It wasn't part of the community. In the UK, where they had ongoing supply of medication in 1965, they decided that was no longer. So there was some brave doctors who continued to supply heroin to people who were heroin dependent right up until 1995, believe it or not. But most of it stopped in about 1965. When methadone was developed and proven to be effective in the 60s, it was a really difficult process to get it out there. I'll talk about that in a minute. 1970, Nixon's war on drugs, and again, we all know about this, how much this has impacted things on all of us. So, and all of our patients, people we see. So significantly having a disproportionate impact on minority communities, and it's been argued before that that's exactly why it was brought in, to be able to target minority communities rather than to have any impact in particular on drugs. So it was always a war on the people who use drugs and a way of dividing people. It's had a huge impact on global strategy. And just going through history and reading about how close we got to having injecting rooms, a heroin trial back in the 90s, it was all impacted by this stuff, by this war on drugs and by what the Americans decided the way the Americans decided the world needed to respond to drugs. So other than policy and government policy, there were cultural factors too. And so in response to prohibition and the lack of kind of medical treatment, AA grew up. And AA has been a hugely significant cultural force, particularly in America. But its emphasis on abstinence has had a huge impact on the way we perceive treatment here. So AA, to their credit, has provided care and treatment and community to millions of people over the years for free. It's pretty amazing. It's an amazing service. But it's Alcoholics Anonymous. So there's not advocacy that comes out of it because it's people being anonymous and not declaring that general things need to change. They also advocated for a time against medication that could help people. And so because they were just suggesting that abstinence is what people needed to go for. And so when the methadone clinics started to open, there was a lot of opposition to it. And that opposition continues today. In fact, my daughter is, because I'm a bad parent, my daughter is a receptionist at Innerspace, where I work. She's quite young. She was telling me today that she had a person call up yesterday who said they'd been doing their research and they discovered that the chief addiction medicine officer worked at this practice. And she said, "What?" The person on the phone said to Tilly, what do the doctors at your practice do? And Tilly said, well, they do. They treat opioid dependence with replacement therapy. And the person on the other line said, so you're telling me that the chief addiction medicine advisor has such a narrow understanding of addiction that all they do is replace one drug for another. So things haven't changed. There's still the same feeling out there that we need to get people off all drugs, despite there being proof over years and years and years of the effectiveness of medications for these things. And there's still some stigma. This still applies a bit. When I started working, so 25 years ago, there were services that wouldn't see people who were still on an opioid treatment program. And there were services that said people need to be on a particularly low dose. And there are still some services around now. Now, I've been very pleased to see that that's been changing. It's changed over the time of my career and it continues to change now, but still influenced by the Harrison Narcotics Act, still influenced by the effect of AA over the years. So the impact today. So in relation to alcohol, we still, and this is what we talked, my colleague Dean and I talked about last year, a lack of medical involvement in alcohol treatment. Even in people who are in liver clinics dying of alcoholic liver disease, people are not very often given the medication that might make a difference for them. And as we said last year, medication, there are other things that people need to help reduce their alcohol use, but medication can play a powerful role, and we need to be throwing the kitchen sink at people in the same way as we would treat somebody with a significant cancer. When you've got a young person dying of a condition, we need to be offering everything for it. There's a lot of blame on individuals. So there's this kind of moral sense that people are to blame. So we can put a bottle shop on every corner and we can have deliveries available and people getting flagged on their phone all the time to say, have you thought about gambling today? But it's the person's fault. It's the individual's fault. So there's an emphasis on the treatment of individuals and not that sort of systemic change that would be really powerful and really make a difference. And there's still an impact of prohibition in the opposite way of what you might think. The same reason I was just saying. So if you start to talk about putting restrictions on, maybe we shouldn't open a bottle shop in this particularly vulnerable community. Oh, it's just like prohibition. We're just going back to some kind of prohibition. And we know that doesn't work. In fact, prohibition worked okay in a lot of senses. A lot of people reduced their alcohol intake, and less people ended up with cirrhosis. So what the argument of prohibition that comes out is that we can't regulate anything. But in fact, regulation makes a difference and is really important, and it's not prohibition. You've got prohibition at one end, regulation is somewhere in the middle, and that's where we should be trying to aim. So continuing impact. In relation to alcohol use, as we talked about last year, only 3% of people with an alcohol use disorder in Australia get access to the medication that is even the first line treatment. In relation to opioid use disorder in Victoria, we're probably 10,000 patients short, we estimate. In New South Wales, there are 25,000 patients on a program. In Victoria, 15,000. Similar populations, and in fact, probably more opioids used in Victoria. And I think that's from a lack of willingness of my colleagues to take up prescribing of these medications. Still influenced by Harrison Narcotics Act so long ago. Other treatments, if we had a treatment, for example, I know we're all fascinated and dying for there to be a useful treatment for methamphetamine dependence. If we had a medication that came available tomorrow, how would our patients get it? Where would they get the prescription from? It's very difficult to get through our AOD system as it is. There's an ongoing war on people who use drugs, and the impact of that has an ongoing effect of stigma and the costs of enforcement. Spending 60% of the money on enforcement, only 3% on the harm reduction side of things. There's still stigma on methadone access, for example, related to Harrison Narcotics Act. Doctors not allowed to prescribe. The way methadone was introduced back in the 60s, where it had to be so strictly regulated. We've got people who've been on methadone for 20 years, still can only get 6 takeaways a week. And we're fortunate in Victoria to be able to get 6 takeaways a week. In other states, it's less. It's 4. 20 years, completely stable, but stuck operating in this particular way. Buprenorphine, really safe medication, much safer than all the other opioids, but for historical reasons was connected with methadone when it first came in, regulated in the same way. There's no need for it to be regulated in the same way, you could argue. In fact, this is from our own policy for maintenance pharmacotherapy, and I have to declare a role in helping to write up that policy. It actually refers to accidental addicts from prescribed opioids and intentional addicts. Can you believe it? This is what's in the document now. So things are still affected, and fortunately, we're making some progress to change that. So what changes policy? There's a whole lot of things. Crisis changes policy pretty quickly. So when we had COVID, all of a sudden, it was appropriate now to do telehealth, to be able to do an opioid assessment for people, and to get them onto a program. We could even send an e-script, which would never have happened if we hadn't had COVID. That, I can guarantee that technology wouldn't have got through all the processes. And we were able to recognise that people needed more takeaway doses. And again, in Victoria, thanks Scott. Again, in Victoria, we're going to continue with our takeaway dose policy because we've recognised that people can manage this. Advocacy, so individual advocacy, Judy Ryan did excellent work in getting the injecting room going. So that individual advocacy can make a big difference. Pioneers and innovators. So I don't know if there's not many people who would remember now in this room that it used to be illegal to give out needles to people, clean needles. It took people at St Vincent's going against the law to provide needles to people to help prevent people getting HIV. And it was hugely effective in Australia. And that policy has continued on, and now we feel it's to be normal. And evidence leads to change too. So we now know that in relation to opioid treatment, that there's the longer people have a period of abstinence, the higher the risk of dying afterwards. And so now we have a process in Victoria where if people go into withdrawal facilities, they'll be encouraged to be on medication that will reduce their risk of death afterwards. So evidence does change things. What else changes things? You guys do. So service providers do. That's a really key thing. I've been really excited going around to various places and hearing people talk about the need to bring in harm reduction measures in facilities that haven't had them before. That's been, workers have come to me and spoken to me about that. So it's really important the work that you guys do in advocating for your patients. You see where things are at. You can see that policies about smoking, policies about vaping, those sort of things make a difference to the people that come into your services. And it's really important for us to be aware of that and to know that. So where are we now? We're looking to destigmatise opioid treatment. So we're doing some work in the department and to reduce that stigmatising language and reduce the stigmatising understanding of things. There was a pharmacist, as we were going through this, who noted that the language of those documents is actually stigmatising towards patients and to the prescribers. There's an assumption that everybody's going to misuse the system, interestingly. We're talking about some changes to buprenorphine. We're getting ready for the potential change in the drug market. And that's something we've got to be, I'm sure you've all heard about with the risk of potent synthetic opioids and that sort of thing. So we need to be ready for that. Addressing alcohol use as part of the strategy, trying to add the additional biological part, if you like, into the biopsychosocial model of dependence, having access to prescribers who can help with medications where needed. Moving from policies blaming individuals to those that change the system. So that's looking at policies that change the way that access to these to things like alcohol is available, utilising the work of the Centre for Alcohol Policy Research at La Trobe, who do fantastic work, and FAIR, who talk about the impact of alcohol on the rest of society, and partnering with organisations like Alcohol Change Victoria. So that's people who are working towards the advocacy of changing these policies that again have been affected by things from so long ago. In harm reduction, amazing week. What an amazing week to have an announcement of a permanent site, a fixed site. And thank you for the Minister for her encouragement about its future. Amazing to think 5 years ago, 10 years ago, we now have an injecting room in Victoria and we have the drug checking facility for people. It's an incredible change. I wonder what in 10 years we'll be looking back and thinking, how things will have changed in that time. I'm really keen that in hospitals and health services, we can have hospitals and health services become places of care and treatment, not places that just assume abstinence and expect everybody to stop using the drugs that they've been using before. Going into hospital is a stressful, painful, often, process. And we have historically in hospitals expected everybody to stop using drugs when they go into hospitals. It's something we need to think about. People miss out on care. People get kicked out of hospital despite needing ongoing care. It's something we're looking to work on. And then there's other responsive policies. So policies that are sort of brewing in the background. So in New South Wales, the Drug Summit on they had a lot of talk about decriminalisation. It's something that for those of us in the sector, it's something for us to be thinking about these kind of regulatory changes. I know Pennington, they've done a lot of work on developing a model in relation to cannabis regulation. So that's going to be something for us all to think about and reflect upon. And having an emphasis on health management and not enforcement, which we all know about. So there's lots of good things that have happened, changes afoot. I'm really keen to hear from you about other things that need to change, things that could make a difference, things that you see in your work that could help, and things that need to change as far as policy goes and the direction that we're working on. Thanks very much.